very much. Assalamu alaikum and good morning. This is the continuation of yesterday's lecture, first of all. Yes. You know, we stopped in the middle of the lecture owing to the shortage of time. We have to finish that lecture first. Inshallah, after that, we begin the next one, which is again a very conceptual lecture. It's about ventilation and perfusion in the lungs. And more likely, this lecture will happen next time. The reason is today Dr. Ibrahim Masoodi will take your lecture instead of me. Second lecture he will take. Is it today or yesterday? Alright. Okay. So today it's the only lecture of physiology. One. Or do you have another one also? Dr. Masoodi will take that lecture because he will be busy in the hospital during examinations. So we are exchanging the lectures. I'll adjust the lecture with Abdullah inshallah. But for right now, we are resuming from where we left the lecture. Alright. Okay. Just have a warm up again. 4 volumes, 4 capacities were discussed yesterday. I demonstrated 4 volumes and I showed you the 4 capacities. You gave me the values also and you calculated the capacities also, if you remember. We talked about it. Can you quickly revise the names of the volumes, the 4 volumes which are present in the lungs? Okay, Abdullah. Inspiratory. Reserve volume, tidal volume, I heard. 2 are done, yes. Expiratory reserve volume, very nice. Thank you. Residual volume. One concept before we start. 2 lung concept we talked about yesterday is that 2 lungs contain these volumes, not 1 lung. We are considering the whole system, but the question is, where are these volumes present in the lungs? Which areas, anatomical? Now you match it with anatomy also, so that your concept is clear. In respiratory systems, where are these volumes present? You are using the word lungs, but lungs is a vague term. Lungs contains different levels of the airways, different generations of the airways. My question is that where exactly do you think these volumes should be present in the lungs? From which level to which level? Yeah. Think positively and just tell me. Yes, Abdullah, can you try?
I think it's from the nose to the alveoli.
Well, Abdullah is saying nose to the alveoli. Let's take this concept. From nose to alveoli, you have respiratory system. But when you are saying these volumes are present in the lungs, we use the word pulmonary volume. We don't say that respiratory system volume. We use the word pulmonary volumes. If I am saying the word pulmonary volume, then it means I am focusing lungs more. But I have to decide from where to where these volumes are present. Think intelligently, yes, my dear.
From after bronchitis, then after to the brain.
From bronchi to the
Alveolar membrane.
alveolar membrane in the after part, the last part. You are saying. Do you want to add something? From terminal bronchiole, you are saying bath terminal bronchiole, after terminal bronchiole. Wonderful answer. Thank you very much. You two actually gathered the answer. Lovely. From nose to the terminal bronchiole, what do you have? Dead space. Dead space already contains some amount of air always module, and that is known as a dead space air. Dead space air is तकरीबन 150 ml. I told you 150 ml तकरीबन. It varies. It usually depends. Obviously, all of us are different, isn't it? Our height is different, our build is different, our size is different, our system's capacity will be different. It cannot be same exactly. Okay? I am talking about the average value 150 ml, but it generally matches with your wazn, your weight in pounds. If you're not a very obese person, you are an average person, then once you become an adult, whatever is your weight in pounds, for example, if my weight in pounds is 170 or 160, okay, my dead space volume will be taqriban 160 ml or 170 ml. It's very easy. If your weight is 140 pounds in pounds, okay, not in kilos, I'm saying pounds, then your dead space volume is taqriban matching with your wazn in pound. That's easy to remember, really, isn't it? Class. From here to here, as they are saying, don't call this volume of air as the pulmonary volume. Why? Because this volume has a makhsus name. You call it dead space volume or the dead space air. Did you get that? After that, when you are starting the respiratory bronchiole, and then you are moving into different generations of airways, and finally reaching the alveoli. So from the respiratory bronchiole to the alveoli, the last part, now the lungs will contain these two volumes, these four volumes, okay? The two lungs. Did you get the difference between the dead space volume and the pulmonary volume? So now you know that where is dead space volume modular and where are pulmonary volumes present in different situations, okay? If I say, I want to know the whole volume of air modular in my respiratory system, then what will you do? You will add these two volumes, the dead space volume and the pulmonary volume. Okay? Dead space volume has its own significance. We talked about that, and we'll talk more about that. And pulmonary volumes have their own specifications or own significance. Alright? The four volumes you have given me. I didn't hear the name of capacities. Can I have the name of capacities? Yeah, quickly.
Vital capacity.
Number one is
Inspiration.
no, before that we began with another capacity. That was during inspiration. Okay, I was considering the act of inspiration. Whatever you are getting inside with your tawil and maximum inspiration, that is your inspiratory capacity. Remember? How much air I am taking by effort maximally, now this air which is going inside is my inspiratory capacity. Remember that? The second one, as you were saying, was vital capacity, which really stands out totally. Out of these capacities, this vital capacity is very, very significant for the clinical purpose because we judge different patients by checking the vital capacity. Right? Vital capacity can be performed and it represents the function and the power of your system, how much power your system has. Vital capacity is greater. It's the average value was 4.6, I think you calculated yesterday.
Yeah.
See, vital capacity. Now, the maximum amount of air which is coming out of the system, that contains three volumes. Remember, three volumes, right? Tidal volume, expiratory reserve volume, and your reserve expiratory reserve volume also. It's a big volume, okay? The tidal vital capacity overall volume is big, and it is about 4.6 liters. But obviously, it varies. Those of us who are strong muscularly and they train themselves in the gym or they are sportsmen, they play, their vital capacity will be much more because vital capacity effort, as you see, comes from your muscle activity. The stronger the muscles, the better the vital capacity. Did you get that? Okay. In this way, if you are comparing male and a female person, who will have a better vital capacity?
Male.
Males are muscular and females have more fat and less muscle. So their effort will not be the same. If they do the same test like I'm doing, their effort and their vital capacity will not be the same. It's about 20% less in females generally. If you are a male person of an average build and height, and if you check the female of same race, belongs to your race, and an average female, then she will have taqriban 20 to 25% less vital capacity, owing to the system difference. We have a difference in our system. Stronger system and less stronger system in females. Are you getting the point? So, one most important factor for the vital capacity is your physique or your build, which is mainly coming from your muscles, how muscular you are, how strong you are in terms of muscles. Okay? And this can be increased if we practice more and if we play or we train ourselves or we do the weight training. Definitely the muscular growth occurs and the person's vital capacity will increase. It also depends on other factors, not only the muscles, but muscles are playing the most important role, isn't it? And overall size of a person, two persons, one person is about 6 feet and mashallah, he has a good health. And the other person, he is also perfectly normal, healthy, but his height is 5 feet only. Who will have a better vital capacity? Person who has the size of the lungs, the size of the thoracic cage, the size of the muscles will be different, even though both are normal, alhamdulillah. They have no problem. But natural vital capacity will be more in a person who is tall and who has a better build, isn't it? Okay, let's talk about the factors very quickly, because we know about these things. We don't want to waste time here. Alright. Can you interpret this diagram very quickly? Very quickly. The first one, the person who is at rest, like me or you, after normal expiration, what do you have inside your system? FRC, functional residual capacity, which is actually 2 volumes. Do you remember that?
Yes.
Alright, great. After your maximum expiratory effort, still your lungs have some volume, you know that. That's RV. Great. And if you are taking maximum air and holding your breath, like I am holding my breath now, and you can imagine how many volumes are now present in my system. And you have the answer. Thank you very much. We talked about those volumes cannot be measured, or those capacities cannot be measured by spirometry, which have residual volume. Can residual volume come out? No. So can you measure it directly? No. So anything which has the respiratory volume, you cannot measure it directly. Very simple. Like you can see, you cannot measure. There should be a special method. Residual volume, lungs, you cannot do that. Functional residual capacity, no way, you cannot measure that. Okay? Oh yes, very quickly, please. The most important discussion out of volumes and capacities belongs to the vital capacity. I told you. Okay, we were discussing that. Look at different aspects of the vital capacity. Very interesting actually, okay, and all logical if you think. I am standing and I am performing a vital capacity. Then I lie down on the floor, or I am lying on the bed and I am performing the same action. In which posture, which condition I will have a better vital capacity? Standing. Do you agree?
Yes.
Why is the standing helping vital capacity?
Gravity.
The gravity is actually taking your organs, Allah of the abdomen, intestine, liver, down. So your diaphragm is free. So when you make the effort, your diaphragm will go maximally downwards, so your lungs will be having maximum capacity, isn't it? If you are doing it in the lying position or turning position, in that way your organs are over the diaphragm. Your diaphragm will try to push, but it will not be the same like I am standing. Okay? It's quite obvious that in standing position you have best vital capacity measured. When you are lying down, or when you are sitting, or when you are bending, then definitely your organs of the abdomen and the surrounding structures, they try to restrict or decrease the vital capacity. Not very much, but some effect is there definitely. Okay? So it will not be the same. Alright. Posture, movement of the diaphragm, sometimes the same concept. A woman is pregnant what will happen to the vital capacity? Right? Logically. Especially the advanced pregnancy. I'm not saying that in the first month of pregnancy, or because at that time, this is the size of the fetus really, okay? This much is the size in few millimeters, and everything is modular in the pelvic cavity. Once it grows up and up and up and the uterus is growing, then obviously you will have the restriction. But before that, there is no problem. Okay? Any other tumor or any other condition, any other growth, okay? Any reason which is stopping the diaphragm from going down, that will decrease the vital capacity. Okay? We talked about the muscles already. Remember? Okay. More muscular, yani more vital capacity. Lung elasticity. Okay. Those who have more lung elasticity will have better vital capacity. It may differ individually, but the elasticity changes with the age also. In a person who is Sheva, the elastic fibers naturally decrease, okay, and some fibrous tissue is coming. Doesn't matter. It's the process of aging. We are becoming old. Okay? So, do you think the vital capacity of an adult person, lung, I am not saying the muscles. Muscles are different in old and young, definitely. But I am considering the lungs. Will that be same totally, the lungs? No, there will be some difference in the lungs. And that will increase the vital capacity in the young age, and that will slightly decrease the vital capacity in the old age. Okay? Multiple factors are there. We have lung compliance. Any factor which is reducing the compliance of the lungs, whether it's elasticity or other factors from outside, if they are not allowing the lungs to expand, if my rib cage is not expanding properly, or other factors due to which my lungs cannot expand or the compliance is decreased, maybe surfactant is less or any other condition, do you think my vital capacity measurement will be good? No. No. It will be less than normal, isn't it? So these factors are quite understandable. If there is a resistance to the airflow, if the airflow is having a problem, for example, some diseases, remember the obstructions of the lungs. I take the air, no problem in my inspiration, because inspiration is making its own way and opening the airway. But when I'm expiring, my system is being compressed actually, and my little tubes are compressed on outside, and if there is obstruction module inside, any mucus or bronchospasm is module, I will have a shadid problem, and I cannot bring the air out. Vital capacity is actually bringing the air out. If you don't bring the air out, what will happen to the vital capacity? Decrease. So typically, your vital capacity will decrease in which type of disorders?
Chronic obstructive.
Chronic obstructive disorders will decrease your vital capacity. Emphysema, chronic bronchitis, asthma, okay, all these conditions typically diagnosed. Tashkhis is made by the vital capacity rate. Okay? One of the parameters of making tashkhis of these diseases is looking at the vital capacity, how much vital capacity has fallen, and we'll talk about one more thing which is coming up. All these conditions, compliance, expansibility of the thoracic wall, I have discussed it already. Pulmonary blood flow. If the pulmonary blood flow is increased due to some abnormal condition, yani lungs are congested and they have dilated vessels and they contain a large amount of blood, this is abnormal condition. What will happen to the expansibility of the lung, or what will happen to the vital capacity measurement? Will it be the same? No, it will decrease in edemas of the lung or in congestion of the lung, in heart failures when the back pressure goes to ventricular failures. You know, the lungs are congested and there is a chance of edema always, pulmonary edema, isn't it? So in those conditions, if you measure the vital capacity, that person of the cardiac failure will have low vital capacity, even though his primary problem is heart, hull, but this heart will affect the lungs also, isn't it? Yeah. Okay. Alright. FRC and the significance. FRC again is important for some clinical measurements. Now, functional residual capacity. FRC should increase in some diseases. What kind of diseases will show an increase in the FRC? FRC has two things, your respiratory reserve volume and your residual volume. Now you can think more in terms of residual volume. What diseases can change your residual volume? Emphysema. Alright, emphysema will increase your residual volume or decrease your residual volume? Decrease? Or increase? Up? Alright, because large cavities are formed inside the lungs, but actually the surface area is decreased. You have broken the septum. Okay? The problem is not only the structural change in the lung, the problem is the obstruction. Is emphysema obstructive disease? Yes or no? Yes. It is one of the obstructive diseases, right? COPD. So it means the air is not coming out. When the person is expiring, the air is not coming out. Sanavat and Sanavat, if you consider 5 years, 10 years, 15 years, 20 years of asthma or 20 years of COPD disease, what will happen to the residual volume of that person? Yeah. In chronic conditions, gradually there is air trapping. The air is trapped inside the lungs and their lung size will gradually increase because air is trapping inside. Okay? So it is a matter of many years actually, slowly, that the lung volume increases, the residual volume increases. If the residual volume increases, will that change the FRC? Yes or no?
Yes.
Because, you know, residual volume is a part of FRC. If residual volume is increasing, FRC is increasing. If residual volume is decreasing, FRC will decrease. Can you name any disease in which residual volume is decreasing this time?
Alveolar collapse.
Okay, one is alveolar collapse. Okay, if there is a massive collapse, then overall your FRC will decrease and the residual volume will decrease. What else? Any other condition? Yeah. If you say acute condition, you say collapse. It's good. Collapse is usually an acute condition. You cannot continue to have collapse for a very long time, isn't it? But fibrosis is a very slow process. Slowly and gradually, day after day, weeks after weeks, months after months, years after years, the person is going into fibrosis and his lung size is becoming smaller. If the lung size is becoming smaller, what will happen to the residual volume? So now you know FRC and residual volume. Which diseases and which diseases? Is that okay? The PFTs or lung function tests, pulmonary function tests or lung function tests, very quickly, let's have a look. In many ways you can check the functions of the lung. There are many different aspects. Some are very important and very common, others are special tests which are used only in special patients and for special purposes. But this is actually a phase, it's a list which is given. You can see that. Pulmonary ventilation checking, dead space measurement, dead space air measurement, how much is dead space. Checking the compliance of the lungs, lung compliance check. Ventilation perfusion ratio, the next lecture is about that very interesting issue of ventilation perfusion lecture. Okay? How much ventilation is going in lung and how much perfusion and blood flow is going on and are they matching with each other or not? We'll talk about that. Lung volumes and capacities that we are discussing, their measurement with the spirometry. Okay? Static lung volumes and capacities. Timed vital capacity. Now, that is something which is our pivot of the lecture today. We'll talk about this special thing. So far, we have not talked about timed vital capacity. We talked about vital capacity, right? Yesterday, we also talked about forced vital capacity. I used the word forced also. Okay? So two terms we have described regarding the vital capacity, but this term, the timed vital capacity, this is a new word for us. We have to discuss that. Maximal breathing capacity and the breathing reserve as special test to check functions of the lungs. Peak expiratory flow. This is also for checking the obstruction basically. It's a very small thing, plastic device. It comes, you put it in your mouth and like this. First you take a deep breath, you pinch your nose and maximally in that little pipe-like device you explode or you simply blow the air. And there is a meter division, and that shows with how much velocity the air is moving in your system, and that tells us about normal or abnormal. Normally any obstruction is there or not there. Okay? Anyway, blood gases. Wow, that's a very, very important thing. Blood gases. When I say blood gases, what gases are coming in your mind? Oxygen. Measurement of oxygen and carbon dioxide. This test is a very, very special test done in serious patients who are undergoing end stages of the diseases like COPD or asthma or any other very serious disease of the respiratory system which is going towards the failure of the system. It means for the respiratory failure, we check these conditions, or in shadid cases of the diseases, we check oxygen, carbon dioxide. I told you, in the beginning of any disease, carbon dioxide and oxygen is not affected. Especially carbon dioxide is not affected. Why? Because carbon dioxide is a very rapid gas. Okay? This test is called ABGs. ABG. A for arterial. Thank you, my dear. Thank you very much. B for blood. G for gases. ABGs. Arterial blood gases. Okay? We check it in the arterial blood because why are we not checking it in the venous blood? Because it already contains a low oxygen, and you will be confused that is it really a low oxygen from problem or low oxygen after supplying the tissues? So you will be confused. So always we take it directly. This test is taken here. We take a syringe like this. In the hospital, when you will be a doctor inshallah, you will be taking the sample of this test yourself. You go to the patient, here is the artery going, the radial artery is modular here, alright? So you just palpate the pulse and directly like this, you enter into the artery. Once you slowly go down in this way, as you go into the artery and cross the wall, you will see a gush of blood coming in your syringe, and then slowly you take that blood. That blood is arterial blood. You will not draw the blood from here. This blood is venous. So you don't draw this blood. You check arterial blood gases, right? In that test, not only you are looking at oxygen and carbon dioxide, you are also checking the pH, and it's about hydrogen ions and it's about the bicarbonate ions. So CO2, O2, pH in hydrogen and bicarbonate. That will give you a complete idea about your system. Is your system going into acidosis or alkalosis? Is this acidosis or alkalosis metabolic or respiratory? Everything will be known by interpretation of this very, very functional important test. Okay? That's known as ABGs, arterial blood gases. Some exercise tests. So sometimes you perform exercise and then you do some testing of the lung function. Because sometimes exercise changes your function. And you want to see, is exercise causing any problem to you? Like in asthma patients or in some patients, after doing the exercise, their problem increases. So for the diagnosis, we also perform exercise tests. And bronchial challenge testing. Sometimes some persons are sensitive. And if you give a substance like histamine or some irritant spray in the system, what will happen? They will have a difficulty, they will go into bronchospasm because they are sensitive or allergic, and that tells us about their problem. Okay? Then we check their vital capacity and other measurements. So if they are having allergy or they are sensitive, then after giving this histamine or some chemicals, what will happen? Their function will decrease. In normal person, nothing will happen. So in this way, you have a range of different tests which can be performed to check your respiratory function. Okay, that was the list. We will pick one most important test, and that is time vital capacity from here. Let's have a run of this time vital capacity. The next slide is showing us, okay? The timed vital capacity is also called FEV1 actually. Okay, it's famously known as FEV1. F force, E expiratory, V volume, 1 in the awwal second of your expiration, in the very first second of your expiration. Now look at me please. This is actually checking the vital capacity. Very simple. I'm doing it. I'm performing. I take a deep breath, pinching the nose, and this is a pipe for the spirometer. Do you have the watches? Okay. Look at when I'm doing it, when I start my vital capacity in it, expiration, see how many seconds is the total time of my vital capacity, okay? Just check it, I'm doing it again, have a look. But from expiration. Now. Yeah, 4-5 seconds definitely, isn't it? Taqriban. Like this, not less than that. Total length, isn't it? Out of that total time, the first second when I began, the first second is the most crucial second or the most important second. My whole force, my whole volume, the maximum volume is coming out in that first second. So the most important seconds, if you divide my vital capacity into 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, the upper second, the very first one, is the very, very important second. Everything is happening in that second. Okay? Actually, if my vital capacity is taqriban 4 liters, for example, I am not a very big person, so maybe my vital capacity is not like 4.6 liters, or maybe it's a little less. Imagine that my vital capacity is how much? 4 liters, which could be normal for every person, no problem. Okay. When I'm doing this function, and I'm checking my FEV1, okay? 3 liters out of the 4 will come in the first second. Can you imagine? 3 liters of the volume will come out in the first second. That is the quality of the FEV1. In percentage, what will be the percentage? 75. 75% of my total vital capacity volume is coming out in the first second. This is called FEV1. Sometimes it is even more. A normal person will have 75% at least, or 80% of the vital capacity coming out in the first second. Can you imagine? Okay? At least 75%. So look at the importance. So in the diseases, in obstructions, in other disorders for tashkhis, this test of FEV1 is very, very important. This is called timed vital capacity because you are looking at the time in the first second, or the second second, or the third second. If your 3 liters out of 4 are coming in the first second, how much is baki? 1 liter. This 1 liter is divided into the other seconds of my vital capacity. Okay? And FEV2 means the second. FEV3 means the third second. FEV4 means the fourth second. In FEV1, how much volume has already gone out? 80%. In FEV2, now if I take 2 seconds, how much volume is gone? 94. How much baki? 6% baki only. So 6% will be in my remaining time. After FEV3, now it's a very little volume. So forget about others. Imagine only one, FEV1. This is actually everything. 75-80% of your volume is going out in Wahid second, and this Wahid second is the awwal second, actually, the first second. Okay? It's not only 1 second, it is the first second of your beginnings. Did you get the idea? Yes. Okay. FEV1, first we measure, and then we take a ratio, please. We measure the FEV1. FEV1 is the volume that we measure. Okay? And then we take the total of the vital capacity. For example, I am doing forced vital capacity. How much? 4 liters. How much is my FEV1? 3 liters. Isn't it? Now I will develop a ratio 3 by 4. Okay, it is 3 liters out of total 4 liters. Okay, this is a ratio between FeV1 and FVC. Did you see that? I'll write FeV1 divided by FVC. How much is my FeV1? 3. How much is my FVC total? 4. 3 upon 4. Now you will get the percentage. How much is the percentage? 75% normally. Did you get that? Mumkin more. Maybe 80% or like this in a normal person. Now, this function decreases, this ratio 75% decreases in obstruction. Because if I have any chronic obstructive problem and if I am performing, then my ratio will decrease, and that is giving you the tashkhis of obstructive disorders. So your obstructive disorders are usually diagnosed on the basis of FeV1 upon FVC ratio. Yani, if you know the ratio, if the ratio is really bad, you say, okay, you are a case of this disease really. Other symptoms and signs, you make the diagnosis. Okay? Did you get the idea? Okay. This is not important. FEF 2575, I told you, it is expiratory flow. A little plastic machine is there in which you blow, I told you. Okay? And that is giving you the speed of your airflow, not about the volume. It is giving you the speed. How many liters are coming per second or per minute? That is the speed. This is also telling you about obstruction. This is another test of obstruction. But you are interested in this one first. Okay? Alright. 70% of the predicted greater than or equal to 70%. If you are going below 70%, normally we have 75%, okay, 80%, but from 70 to 80% it's okay. We are normal. We don't have any obstruction. If you are going below 70, then it is the beginning of the obstruction. So you have a percentage in mind. If you are going below 70%, this is the beginning of obstruction. And if it's going down and down and down, your obstruction is increasing. Okay? Darajat of obstruction. Mild, moderate, and more. Okay? So if your obstruction is very much severe obstruction, then your ratio will fall to less than 50% or even less than 45%. Okay? In many patients. So this is called the FeV1 upon FVC ratio. These are the obstructive and restrictive disorders which we have already talked about. Examples are given. Main obstructive disorders, forget about the cystic fibrosis here, asthma, emphysema, chronic bronchitis, these are the obstructive disorders. And restrictive disorders, you gave me all fibrotic diseases of the lungs, interstitial fibrosis, or if you remove the lung due to cancer. If I remove one lung from the patient, what will happen to his total lung volumes and capacities? Decrease or not? No, isn't it? So it's kind of a restriction which is coming, and the total mass of lungs is reduced. Any condition. Now, if we are developing fibrosis in the lungs, then it is the intrinsic disease of the lung which is happening in the lungs, and restriction is due to lung disease, tuberculosis, any other condition, cystic fibrosis, any type of fibrosis in the lungs. Okay, this is called intrinsic. But if I am having a problem in the pleura or the thoracic cage or vertebral column, any other problem, what would you call it? Extrinsic. You can have restrictive disease due to extrinsic reasons. You can have restrictive disease due to intrinsic reasons. Okay? All right. Obstructive disorders. What will happen to the forced vital capacity in obstructive disorders? Decrease. Alright, okay. In the beginning, if I'm developing obstruction, mild fall, okay? In the beginning, my total vital capacity will be the pre-birth norm. No problem. Okay? but my FEV1 upon FVC ratio will decrease. Okay? So total vital capacity is तकरीबन normal. If I make an effort, I'll get the same amount. No problem. But if I'm developing moderate disease or severe disease, then my forced vital capacity, the total one, will also decrease. And FEV1 or FVC ratio will go very low. Okay? So in the beginning, now you can say that FVC may be normal in the beginning of your obstructive disease. And later, it can become decreased. Your FEV1 decreases, okay, from the beginning. Okay? And what will happen in the advanced disease? Your FEV1 upon FVC ratio will show a decrease. So in any level of obstruction, now you tell me, your ratio, FEV1 upon FVC ratio, will it be normal in the beginning of obstruction? No. You define obstruction when your ratio becomes less than 70%. Do you remember that? Yes. Yani ratio is abnormal from the beginning, but your forced vital capacity, the total one, mumkin, it is normal in the beginning, but later it will decrease with a problem. Alright? So normal or decrease. Do you see that? What will happen to your FEV1 in obstructive disease from the beginning? It is decrease. What will happen to your ratio, FEV1 upon FVC ratio? That will decrease. Did you get that? Okay. What will happen to the total lung capacity in the beginning of obstructive disease? Normal. In the advanced form, Shadid form, many years after, what will happen? It will increase. Why?
Residual volume.
Oh yes, trapping of the air, obstructive disease. So air is trapped years after years after years, and lungs have more volume. And now if you are checking it, okay, total lung capacity. What is total lung capacity? You are doing only inspiration. Bas, that's it. It means you are taking the air. In the obstructive disease, please remember, is there a problem of inspiration?
No.
There is a problem of right? So you can take the air inside. So your total lung capacity will be more than normal, slightly more than normal. Did you get that? Okay. This is the issue of your obstructive disorders. Come to the restrictive side. Your forced vital capacity will be decreased. Okay, from the beginning. Alright? Your FEV1 will also be, as compared to a normal person, your FEV1 will be less. As compared to a normal person, your FVC is less. Now look, this is restrictive disorder. This is vital capacity FVC and this is FEV1. Okay? Alright? In case of the obstructive disease, what's happening please? FEV1. This is FEV1 and this is FVC. Two things. In the beginning, what is happening? FEV1, FVC is normal and FEV1 is decreasing. Do you get that? FEV1 is decreasing. Alright? So if you see the ratio is less. Okay? Now, in case of Shadid disease or advanced disease, this is, now I'm going, both are coming down. But look, who is coming down more?
FEV.
So the ratio fall will be more, isn't it? Okay? It will be a change. It will be a greater fall in FEV1. So your ratio becomes very bad, low ratio. Look at the restrictive disease now. Okay? What is happening to both?
Decrease.
In beginning of the disease, what is happening to both in the moderate form of the disease?
Decrease. Both.
Like, okay, it's taqriban like this. It's going together. If they are going together, what will happen to the ratio? No. That's the most important point. The ratio will not change. If both are decreasing, if two things are decreasing or increasing in the same magnitude, will the ratio change? No. So, this is the diagnosis. If the ratio is going down, this is what disease? And if the ratio remains same, even though your values are low, but your ratio remains the same, what will happen? It's most likely a case of restrictive disorder. Sometimes the ratio is increased in this condition. It may be the normal or the ratio is increased. Think and answer, okay? I am leaving it to you. You will answer this portion. Why ratio increases in restrictive disorders? Normal ratio or same ratio? Khalas, understand. But why slightly increased? We'll talk about that. This is the comparison FEV1, FVC and FEV1 upon FVC. You will make a comparison. Normal person, obstruction and restriction, okay? This is, you will understand the chart yourself. I'm giving it to you. This is it. We will continue this discussion of obstruction and restriction very much in a tutorial, and we will design the cases. How do you diagnose obstruction and restriction? Is it a mixed case or one case or the other case? You will examine the values and you will answer the questions inshallah. Okay? Did you get the main idea of obstruction and restriction? Thank you very much. We are done with this lecture. Next time we take pulmonary ventilation and